So I'm going to give you a sort of a quick journey through some of the work that we've done, focused on this issue about the relationship of patient engagement and patient experience to quality, safety, and outcomes. I'm just opening the door here. You'll hear many really exemplary stories today, but I'm going to try and frame this in a broader way. So we live in a very challenging time. It is the perfect storm for healthcare right now. And if you saw the movie, you know that it wasn't a great ending in that perfect storm. And so our job is to make sure that we end up through this perfect storm with our healthcare system intact, in fact, more than intact, providing better care, reliable care to people 24/7. And it's a very challenging job. We have lots of good people in the system, but they're working very hard, and it's very difficult sometimes to deal with all these emerging issues. Those of you here were last night, Shalom Goberman talked about the sort of change in the demography, the epidemiology of healthcare, the focus to chronic disease, and the sort of challenge we have now to reorient our healthcare system. And these other changes that are happening as well create a huge sort of issue for us in moving forward. So the question we face now in 2014 is, can we improve the quality of healthcare? Can we move from isolated incidents of high quality, excellent care to reliable care across the system without spending more money? We're going to have some increases, but in limited areas. But the global picture is we need to do more with the resources we already have. And that means we need to get everybody, not just the leaders, but the frontline providers, on the same page about understanding the way in which we're currently delivering care and reworking the design of healthcare delivery at a team level, at an organizational level, and at a system level. And the leadership of the system is really critical, but it's the front line that will make the difference. And I would argue that it's the front line in partnership with patients that will make the difference. Because as much as healthcare has changed in the last 40 years, some of the residual issues about hierarchy and relationships and professional pride that goes beyond the necessity of daily practice into interfering with our ability to reshape, to reform the delivery of care, will be broken down if the conversation includes those people who receive care and who are interested in the outcomes and the experience, and not the titles of the people that are providing them care. And I don't say that to be critical of any one group in particular, but I think it's a challenge for the system as a whole. So where are we at in patient engagement and patient experience work? This is, I think, an interesting challenge, and it's when I reflect back on what happened in the patient safety work a decade ago, with the development of the Canadian Patient Safety Institute, the release of the adverse events study, and a variety of other events, there was an avalanche of activity across this country. And what we see now in patient engagement is a much slower uptake. And so we have to figure out a way to make the case about why this is a critical thing, not only because patients are and should be treated at the center of the system, but because their involvement, their engagement, I think, is critical to the transformation, the redesign of the system. So in 2001, the Institute of Medicine in the United States released a seminal report, maybe the most important report in this decade or this last 15 years in terms of setting directions for healthcare systems, not only in the US, but really around the world in developed countries. And they said that the quality of healthcare is composed of 6 dimensions. That excellent, high-quality healthcare had to be, first of all, safe. It had to be timely. People had to get access to the system in a reasonable period of time. It had to be effective. We had to do the right things. It had to be efficient, right, using resources wisely. It had to be equitable in terms of demographics, in terms of geography. And it had to be patient-centered. And that statement of those 6 goals really changed the views of policymakers, organizations, and providers over time in terms of what has to happen. Of those 6 goals, I think the one that has been most difficult has been this goal of creating patient and family-centered care. So despite the efforts of a number of leaders and groups in this country and in the U.S., the Institute for Patient and Family-Centered Care, in particular in the U.S., and now the Canadian Foundation here in Canada that has taken this up, and a variety of organizations like MUHC, which stands among the leaders in this country in doing this work. This continues to be a challenge moving forward. And so, although many organizations say they are patient-centered, the experience of patients going into those organizations does not live up to that bold statement. So you go to the website of every healthcare organization, and I defy you to find one that doesn't proudly proclaim that patient-centered care is at the core of their mission. But the experience of patients on a day-to-day basis is often very different. So it's not easy to do. And at a system level, as Don Berwick said now 6 years ago, we have to think about the future of the healthcare system, not just in reducing costs or improving quality, or just in the experience of the patients, but in all 3 of those together at the same time, holding those 3 goals, the triple aim, together across the system. This is a huge challenge, and it requires that we really involve many, many people. So I want to spend a little bit of time saying something about the research on patient-centered care. There have been a variety of studies in this area, and a recent review that brought this material together by Cheryl Rathert and some colleagues at the University of Missouri identified that the research as a whole says there's a generally positive relationship between patient-centered care processes and intermediate, that sort of immediate and long-term outcomes. It's particularly visible in the work on patient satisfaction, on self-management of care, and there's some evidence to suggest that this is also the case for longer-term outcomes, but the evidence is still kind of mixed. And why is this important? It's important because in this world of evidence-based healthcare, evidence-based policy, evidence-based nursing and medicine, we need to build a case that says investing in the patient experience, investing in patient-centered care is the right thing to do to get us to the outcomes we want, to the quality, safety, and efficiency outcomes. So if we're going to influence senior leaders in this system, we have to make that case at the ministry level, at the CEO level, at the level of the system as a whole. And so that was going into this environment where we knew that there was lots of positive response at an individual level, and some studies that supported the idea of patient engagement as a strategy to improve overall performance, that we did this work funded by the Canadian Foundation for Healthcare Improvement and the Max Bell Foundation, where we in a series of efforts followed the initial 17 teams that were part of the Canadian Foundation Patient Engagement Project. We did a literature synthesis. We looked at Web 2.0 strategies for patient engagement, and did interviews and case studies in different jurisdictions. And I'm going to focus on that last piece, the case studies, to see what can we learn in different areas. The case studies happened in 4 different countries, and we did this deliberately because we wanted to understand what was unique about patient and family-centered care, patient and family involvement in these different centers, to see if we could learn something from the different experiences, but also because we were interested in this question: did the policy regime that varies across these countries make a difference to local efforts? So in England, this notion of patient and family involvement has been a very hot, very critical issue. And the government, the NHS, the Department of Health, has been very, very sort of vocal on this issue, particularly in the wake of the Mid-Staffordshire inquest and inquiry by Francis. So we thought, well, maybe the flavor will be different in England. The US has had a lot of work in this area as well, and Canada has been much more quiet. The policy environment, the leadership environment on patient engagement and patient experience is only now becoming animated. And in France, it is the law that one must involve patients. But as we all know, just because it's the law, it doesn't mean the right things will be done. And so Marie-Pascale Pommet has done some work which we have integrated into our findings, case studies in France. So the key issues, as I've said, we're really understanding these organizations in these four different environments to see what strategies they were using to engage patients, the impact of patient engagement on service delivery, and what factors contributed to the effectiveness of these different efforts. And we deliberately tried to pick out organizations that were on the right side of this continuum that comes from the work of Paul Bate and Glenn Roberts, who said, organizations can do a lot of things in terms of interacting with their patients. There's lots of things on the left side of the continuum here where we're collecting complaints and we're getting survey data and we're sort of interviewing patients one-off. So the information is coming in. But what we were really interested in was the partnership side of this, on the right-hand side of this continuum. So what does it look like when organizations deliberately try to partner with patients and ask them the question, how can you help us redesign the way in which we provide care in this organization? And that's, as I will come to in a moment, a really challenging thing to do. Now, there's been a lot of work, particularly in England and the US, on determinants of high-performing patient and family-centered care. That is, efforts by individual clinicians or groups of clinicians to involve the patients in decisions about their own care, the choice of treatments, the timing of treatments, the place of treatments. But what we really wanted to do was to focus on the engagement of patients in the design of care for people like them, not just them alone. So if you're a multiple sclerosis patient, how can you help us design the care that we're providing for all the patients we see who have multiple sclerosis, some of them like you and some of them from very different backgrounds? How do we integrate the care that we give in the hospital, the care that's provided in the community? Those kinds of fundamental issues. And so this work that's been done looking at individual organizations need to now be expanded to think about the work at that more complex consultation and engagement effort. And our large high-level findings on this suggest that there are three critical processes that must all be present and interactive in order to have true patient engagement that makes a difference for patients. The first of these is, and it seems really obvious, that organizations have to think about how they identify, recruit, orient, and support patients who are coming in to work with them on the redesign of care. This actually is a challenge for many organizations. And when you talk to people in the organizations about how they do this, they say, well, Mary has worked with us for some time and we really enjoy that. Yes, and? All right. So how do we make sure that it's more than just Mary? Because it is typically middle-aged or older white females, often not in the workplace, who are involved in these efforts. And that's not bad. That's a good thing. But many of our patients don't look like Mary and don't have an experience like Mary. So we need to think about a strategy that engages a broad demographic range of patients. Not just the ones who are initially easy to work with, but the ones who have a variety of different experiences. And organizations that have been successful at patient engagement have created a group of people who help to orient, support, and integrate the work of patients into the ongoing work of the organization at all levels. Now, those of you who are staff are now thinking, oh my God, it's hard enough to get through my day as it is, and you're asking me to now work with patients who didn't go to nursing school or medical school or pharmacy school, whose only experience of healthcare is the experience they personally have had or that they've heard from their friends and family, and to bring them into a full partnership, a full conversation. That is a challenge because if we don't have the initial openness and acceptance of this as a strategy in moving forward, what we'll see is pure tokenism, right? Or I don't know if you've ever had this experience where you've been in a long, complex meeting with decisions made, and at the end of the meeting, somebody looks at the patient in the room and said, "So how did you feel about that?" Right? And typically you say, "Wow, very interesting. Wow, I learned a lot," but that's not engagement. That's sort of passive participation. So this notion about engaging staff to engage with patients says, how do we help the staff become full partners? So the support mechanism in the organization are not only working with patients, they're working with staff. They're saying to staff, the way to a different future is by figuring out how to have this deep conversation. And some of the work going on in England, experience-based co-design, puts patients and staff together on improvement teams working to make a difference in the community, in hospitals, and so forth. Now, this is very different from the life that we know it, and MUHC and organizations across the country are facing huge pressures, budgetary pressures, huge pressures to do more with the same or even fewer staff. And so the staff look at this and they say, well, on the one hand you say we need to see more patients, on the other hand you say we need to slow down and talk to the patients. There's something wrong with this picture, right? So bringing those pieces together, making sense of this, not only at a senior leadership level but at a frontline level, is the job of leaders. So this third process, ensuring leadership support, is the glue that holds the rest of the pieces together. And you can have isolated bright spots of high performance in organizations without senior leadership support, but you cannot have organizational-wide engagement on patients without bringing the whole range of leadership into this. So just some examples on this. One of the organizations we looked at, Georgia Regions Health System, which is a medical school and a hospital in Augusta, Georgia, has been working for 20 years on patient and family-centered care. They have now 200 patient and family advisors working throughout the organization, 200. And they have staff who support those advisors. And the advisors work for a while, and some of them take leaves from that activity and come back. Some of them have been there for a long period of time. And what has changed in Georgia Regions is the culture of decision-making. So if a critical decision is being made in any area of the hospital at Georgia Regions, one of the questions that gets asked is, what do the patients think about this? What input do you have from them on the nature of this decision? And reflect in your own mind on the experiences you've had in your own environment, the extent to which those questions are being asked in the organization in which you work. So that's the journey, that's the transformation that has to happen in the views of staff and senior leadership and patients in order to make this work. Northumbria Healthcare Trust, which is a trust in northeast England, just outside of Newcastle, works with user groups not only in the hospital but in the community. So when they thought about stroke care and how to improve stroke care, working with the stroke groups in the community, what they discovered was it wasn't an issue of redesigning care in the hospital alone. It was an issue about supporting people once they left the hospital to make this connection, right, which is an issue for many people with stroke and other conditions, about this transition from the services in the hospital to the services outside. And then we need to continue to think about these issues of integrating patient engagement efforts with organizational work. In the leading organization, these things are seamless. Patient engagement is just the way we do our work. We have patients at all our committees. They're part of the conversations. They contribute to the decisions, right? And that's not an easy place to get to. So there's some questions here. How do we transfer the lessons of these leading organizations to create meaningful dialogue, to move from the individual assessments of one or two patients to a broader sort of understanding about the way in which care processes now work? How do we link the information from these patients in their various experiences, right? So we collect data and surveys. We have patient advisory councils. We have this work of patients on various teams. How do we integrate those various components together so we have a much more synthesized and integrated view about the patient contribution to organizational life? One of the things that we saw in England, in Northumbria, was this real focus on creating real-time feedback. And the underlying idea here was that most staff in most hospitals get very slow feedback on their performance. They get surveys that are 6 months, 8 months, 12 months old, and they can't remember what happened 12 months ago, and so the survey is kind of meaningless. In Northumbria, they said, let's give people more or less instant feedback on the experience. So it's not pure real time. In fact, the capability exists to do that, but it gives people a sense now of how did we do last week with the patients that we saw? What did they say to us? What particular feedback do we get from them? So I think this is very powerful moving forward to open that window onto people's experience so that they see it's not only how long it took to discharge, but it's also the question about what was the experience of the patient while they were with us. So that's a critical issue. The second critical issue is how do we engage patients? And I have been involved in quality improvement efforts for the last 25 years, and it's been enormously rewarding. And I think that quality improvement really opens the door for a partnership between patients and staff because it provides the tools that allow people to understand how they're currently working and how it might be different. And in many ways, it also is an opportunity, because many of the staff have not been trained in quality improvement, to level the playing field a bit between staff and patients because they can learn together. And I know the experience at MUHC and transforming care at the bedside had many of those elements in it, this partnership between staff and patients, learning the tools, applying them to the local setting, and then together deciding what kinds of things could be different. And we saw the same sorts of issues in Cincinnati Children's Hospital, which is one of the preeminent pediatric centers in the U.S., not only a preeminent research center, but probably the pediatric hospital that has the most integrated and advanced patient engagement in the U.S. Saskatoon Health Region, and in fact many regions in Saskatchewan, have been involved in integrating patients into their lean rapid process improvement workshops so that the patient is a participant in that improvement efforts. And then I've already mentioned the UK projects on experience-based co-design, which show the power of this partnership between patients and staff. Still, there's many questions about this. How do we expand this? How do we spread this up in a way that allows us to use this kind of system redesign, not just in one or two areas, but much more globally? Organizations find it takes a long time to get each unit up and running. So how do we speed this process? How do we make this happen more quickly? Because we really need to get results that start to show significant differences in a much faster time frame. So scale and spread are critical issues. And I've said this before, leadership connects all these efforts. It's the job of leaders to make sense of the confusion of daily life, the larger strategy, and to create a coherent picture so that staff, patients, and the community know where the organization is going and how it's getting there and what the current progress looks like. Leaders provide the glue to these patient engagement efforts. They allow staff to organize and make sense of the work that sits in front of them, and they provide inspiration, I think, to patients and staff in moving forward. But it's not just leadership at the top, it's a distributed leadership. So the challenge is to make sure that the nursing leaders in units across the organization, the chiefs of medicine and other services, the heads of pharmacy are all aware of this. They're all participating. They're all asking this question, how do I contribute to this larger work, and role modeling this. And that's really important because the work of the nurse in a unit is really shaped by the attitudes, behaviors, and thinking of her leader on that unit. There's a great saying that Ron Heifetz, who's a leadership expert at Harvard, says that really what interests my leader fascinates me. Everybody's looking to the people who are their leaders to find out what's really important, and that creates an environment in which we have to move forward. So the work that we've done, and I've only given you sort of brief snapshots on this, is that many organizations have discovered that involving patients and families in quality improvement, safety, service redesign accelerates not only the redesign, not only the work to improve care, but also the process of patient engagement. It's a win-win here, right? So I've said patient engagement is tough work, but let's make that work focused on something that is really the absolute critical issue for our healthcare system, that is redesigning care to fit the 21st century. The evidence is not really clear on whether or not these kinds of engagement efforts are going to make a difference. There's lots of individual stories, but I think what our case studies have shown is that context is really important. So measuring the experience of patient engagement across organizations, some of whom are half-hearted about their patient engagement efforts, with those that are truly committed to this, is a bit of a washout of the results. We need to figure out where people have made a difference and then look at those strategies and borrow them in other settings. So the bottom line here is the change in individual values, individual behaviors, what we call at a more macro level, the culture of the organization. And many people will say, well, we'd really like to do this, but our culture doesn't support it. And I have to tell you, I think that's a cop-out. We have to start where we are with the resources and the people that we have and support those who are doing the right thing, engaging patients, making a difference in the care that's being delivered. And it's by doing that that we shift the culture. So this notion that culture provides an excuse for not acting, I think, is not the right view of the world. The culture is changeable. Organizations do shift. You see some of these units that have been involving patients. Life is different there. The way in which people work is different. The experience of the patients is different. And that's what we have to strive for. So at the end of the day, I think this is critical work. This is the work that will help to reshape, reform our system. And leadership at all levels, at the senior levels, at the middle levels, from patients, from staff, is really important to make this all happen. Thanks very much.
Your brains are probably whirring at the same rate that mine is as you hear and think about the kinds of critical elements that Ross has described through the case studies that they've done, that he's done worldwide, really. So it's a wonderful start, and I look forward to the ongoing dialogue through the day. We have time for maybe one question.
Thank you very much for that very interesting discussion. I'm Lucia Fabian. I'm the Associate Director of Nursing and Neurosciences, and I think what I'd just like to hear a little bit more about is the professional pride piece that you referred to. I could easily be accused of nursing chauvinism, but I like to think that as I've aged, that I've become wiser and that I've been actively engaged in breaking down the barriers between the professions in order to really listen to what patients and families need and what we need to do as a team to provide the best possible care. So I'd like to hear a little bit more about the specifics of what you're referring to and perhaps some of your more pointed recommendations, because it continues to be an issue 38 years into my career for sure. I see it on a daily basis, and sometimes it's quite discouraging.
Yeah, it's a challenging question, and I could probably learn more from you than you will from me, from your experience. What I have seen is the importance of people understanding their work as nurses, as doctors, as pharmacists, other professionals, as managers, right? Understanding their role in the system, but not letting their view of what their professional identity is hold them back from the effort to work with others to improve the care in front of them. And I think that's even more important with patients. There is a tendency sometimes as professionals to see people as patients rather than as contributors to the healthcare system. And I think we need to change that. We need to reform that. We need to say, as a professional, you're not only providing care, having this very critical relationship, one-to-one, or as a team to the patient, you're also in partnership with the patient around the care decisions for them and around the decisions that we need to make in the system now to improve the care. And sometimes, I'm not saying this is always the case, but sometimes what people hold back on that because their identity as a professional, and I think it's a misinterpretation, but their identity as a professional prevents them from saying, I want you to contribute to the understanding of how we could provide better care for our neurosurgical patients, right? I think that's the issue. Let's open that view a little bit more. The patient didn't go to nursing school, but the patient has a unique perspective here as having had this experience on the unit in working with nurses and doctors and others. So that's all I'm saying here. I'm a huge believer in professional competence, professional practice as a critical element of, so don't misunderstand me here, I'm not saying that's not important, but I'm just saying sometimes it spills over into an inability to be open to the views of people who don't come from the same background.